Hi, good afternoon, everyone, and thanks so much for joining us for today's PSYCKES for Network Users. My name is Chris McLaughlin, and I'm the Director of the Medical Informatics Unit, and I will be leading today's training. All right, so let's talk about how questions can be addressed during today's training. So as you might have noticed, all phone lines have been muted to prevent any background noise, and as you probably heard earlier in the training, we are recording this, and we will provide the slides and the recording to all individuals who have attended today's training, and we'll also be posting this to our website shortly thereafter. If you do have a question, we ask you to use the Q&A feature in WebEx, which is located at the bottom right of your screen. Or if you have your screen expanded to full screen, you'll just want to hover over at the top, and there's an option for more at the right-hand side. You'll type your questions using the Q&A feature and submit to all panelists. We suggest submitting to all panelists and not presenter because I might be busy presenting and miss that you got a question in, but we have some folks from my team, including Michelle Rahm and Melanie Martucci, who will be assisting me in answering any questions that may come in today. We ask that you do not use the chat function for Q&A as that will not be monitored. We have a lot of slides to go through today, so even if you have a question early on, we do suggest you typing that in right away because we're going to be spending some time at the end of today's training webinar to open it up to questions, just to make sure we get through all of the slides. So even if you ask a question early on, don't worry, we'll make sure to address it at the end. All right, so let's talk about some of the topics for today's training. So we're going to talk about PSYCKES overview as we do at the beginning of any training, just to make sure we're covering for any of our new users who have gotten access to PSYCKES and they're curious of how to use it. We'll do a quick PSYCKES overview. Then we'll talk about how to access client data, and this is a brand new feature for our networks. So all networks now have this new capability of having consents via their network providers being sent forth to the lead network. And I'm going to talk a little bit more in detail about what that means. And then we're going to talk about how network users can utilize PSYCKES via population health and the recipient search, quality improvement projects in the MyQI report, and be able to drill down to those client level details in the clinical summary and utilization reports to help, figure out maybe who else should be in your network. And then again, we'll end with some training and technical support and leave plenty of time for questions. So with that, I'm just going to go ahead and jump into the PSYCKES overview. So what is PSYCKES? So PSYCKES is an online web-based application that can be accessed on any internet browser, and it's secure and HIPAA compliant. And the main purpose of the PSYCKES application is for sharing Medicaid claims and encounter data, as well as other state administrative data. So what we do with all of this information is that we put this into a user-friendly format, and it's designed to support clinical decision-making on an individual level, as well as quality improvement and population health management on that more provider population trend level. And you can use the data that's collected in here to help make plans for an individual client or have interventions scheduled for your entire network. The options are endless. When we talk about data, we have to talk about when that data gets updated. So for things like the clinical summary information, that's going to be updated on a weekly basis, whereas the quality indicators or the quality flag reports are updated on a monthly basis. So now that we know what PSYCKES is, who am I going to be able to view in PSYCKES? So in order to be in the PSYCKES application, an individual needs to be considered part of the Medicaid behavioral health population. So what do we mean by that? So what we mean is that they have to be, let's start with Medicaid first. So what does that mean? So a Medicaid enrollee, that's someone who is either currently or previously enrolled in Medicaid. And this is including the fee-for-service folks, the managed care enrollees, even including for those dual eligibles. So let's say, for example, the Medicare Medicaid population. So we will be able to include information for this population in PSYCKES. However, the information will not include the Medicare data because that's just not one of our data sources at this time. That's something that we're really eagerly looking forward to in the future being able to provide. But if there is a client who's considered dual eligible, and let's say that dual eligibility includes them being Medicare and Medicaid, what we are able to show is anything that's paid for by Medicaid. And we let you know at the very top of the clinical summary that this person is this dual eligible Medicare, Medicaid individual. All right. So now that we've talked about what it means to be the Medicaid part of the definition, what does it mean to be part of the behavioral health aspect? So the behavioral health population means that this person has a history of either a psychiatric or substance use service, a psychiatric or substance use diagnosis, or have been prescribed a psychotropic medication. So in that first bullet, you see that we have over 11 million of those clinical summaries available in PSYCKES for this population. But just because the population is based on the behavioral health population doesn't mean that we have information that's limited to just behavioral health. And my next slide is going to go into more detail about what that means. So what data is going to be available in PSYCKES? So the clinical summary is that individual level report for one person, and that can provide up to 5 years worth of information, which we update on a weekly basis. So it's really important to understand, so what data makes up this clinical summary? So there's 2 separate buckets of data that we kind of consider. So the first bucket is that Medicaid bucket, that billing bucket. So we're getting information from Medicaid fee-for-service claims and managed care encounter data across treatment settings. So you see in this little sub-bullet here, that's including information about medications, medical behavioral health outpatient and inpatient services, ER visits, care coordination, residential details, laboratory, et cetera. If Medicaid is paid for it, we're able to display that in the application. But just like I was talking about before, when an important aspect to any time you're talking about data is when you're talking about the time or the lag in the update. So the time lag in PSYCKES can vary upon a couple of different things when it comes to the Medicaid-related data. So first, it's going to depend on the type of information. So something like pharmacy claims, we actually consider that pretty quick and timely. From the time that the person picks up that prescription to the time that it shows up in the application can be as little as 2 weeks. So that's something that you're able to kind of keep a very close eye on and being able to see that information. However, things like outpatient and inpatient services, those tend to take a little bit more time from the time that the service actually occurred to the time that it's available in the application. And that's going to depend on a couple different things. So first, it depends on how quickly and how accurately the provider themselves have billed for this service. Let's say for a provider, for example, their billing practices is that they bill all of their clients at the end of the month. Even if they've provided them services in the very beginning of the month, already you're adding a month's lag to that data. So also the data has to be done accurately, right? So let's say they're submitting it to the managed care plan and that gets sent back to the provider. Again, that's adding time onto when it can be shown in the PSYCKES application. So it goes from provider, let's say, then goes to potentially managed care plan, and then it goes into the Department of Health. The Department of Health is the feed that we update on a weekly basis. It just depends on how long it takes to get to that feed in order for us to be able to display that information. But we have a variety of different administrative databases that we're able to link up to. And what's great about these quote unquote real-time data sources is that the lag here is anywhere between 0 and 7 days. So our most recent data source we were able to integrate into the application is coming from Rikers. So we have New York City Correctional Health Services available in the application. So this jail-based care where you can see when did they get admitted into the jail, when were they released, did they have any mental health housing while they were at Rikers? Did they have any special appointments scheduled for them after release or any referrals? What behavioral health diagnoses might they have received whilst they were there? So a lot of information that can help give that fuller picture of the client. Same with the New York City Department of Homeless Services. So here you're able to see not only if this person is currently at the shelter or had previously been at the shelter, or if they're even considered at outreach at the shelter. You'll be able to see the name of the shelter, you'll be able to see the borough in which the shelter resides, you even get a contact information for the shelter if you do have questions. We also have Health Home Enrollment and Care Management Agency provider information that we get directly from MAP. We also have managed care plan and HART status that we are able to receive. We can even get the assigned primary care physician information related to managed care plans if those have been assigned. We also have a direct link into our state psychiatric center's EMR called MARS. So if your client has had any, or if any of the individuals within your network has had at any point in time been to one of the state PCs, we'll be able to indicate that in the clinical summary. We also have data coming from TACT for our AOT provider information. So if someone had been previously or recently had an AOT court order, or if they have not, that court order has expired in such and such time, we would be able to display that information for you in the clinical summary, same as the ACT provider treatment contact information. And what's great about this is that it gives you the name of the provider and someone who you can be in contact with. We also have information about OMH, Adult Housing and Residential Program information, and that's coming from CARES. We have suicide attempt information that's coming from the state's incident management system. And unlike the Medicaid claims information, which can go back only 5 years, things like suicide attempts, because it's such a critical piece of information, we're able to expand that view to as long as it has some sort of, if the provider has entered in that there has been a suicide attempt, let's say for an individual that happened 10 years ago, 12 years ago, et cetera, we'll be able to display that in the application. We also have the ability for folks to indicate safety plans or screenings and assessments, and that can be done in the My Choice application as well as in our mobile applications. And then we have intensive mobile treatment and AOT referral under investigation that we're getting from DOHMH's MAVEN system. So lots of different data sources that give us the fullest picture of what this data could look like. So next, I'm going to talk a little bit about the quality indicators or flags. So OMH has identified a number of health conditions or treatment issues that were deemed important enough that they were worth scrutinizing. So what PSYCKES does is that it tracks these individuals who are positive for one or more of these quote unquote flags. And that way the provider, the managed care plan, the network, or even state government leadership can be made aware and hopefully make the correct interventions to help assist those individuals, because that's something that PSYCKES does. Unlike some other types of measures, what we show is, hey, who's in trouble? Where can we get the help for these individuals because they're having these particular issues? So we have things like health home related. So those are the eligible for Health Home Plus, but not receiving those services in the past 12 months, past 3 months, right? So people who are eligible for this higher level of care but aren't receiving it, we're going to be able to flag those individuals so everybody can be made aware of that have served this client. Medication related, like polypharmacy, or medication adherence. So that could be something like where a client is on multiple antipsychotics or multiple antidepressants, or if a client has started an antipsychotic medication but didn't remain on that medication for more than 80% of their treatment period. We have hospital-related flags, so high utilization. This is going to be looking at clients, let's say, who have had multiple hospitalizations in the past year. And also those who are readmission, so clients who might be cycling in and out of the hospital. They got discharged and they ended up right back in the hospital within 30 days. Then we have our general medical. So like if someone hasn't had a diabetes screening while on an antipsychotic, or if they haven't had an outpatient medical visit in the past year. And then we have some of our more DOH-related flags. So these are our performance tracking, which have a little bit of a different mature data lag here. Comparatively to some of the PSYCKES run measures, but these are really important measures too, right? So no follow-up after an MH inpatient. So if someone did not get a follow-up visit after they were released from an inpatient visit within 7 days, within 30 days, that's someone who's going to be flagged. So now that we've done the overview, let's talk about some of these new features that we have related to our network users. So first is, how can lead networks access client data? So now, after our latest release, consents and clinical emergency attestations entered into PSYCKES by your network providers, in which you have a data sharing agreement in place for, will be able to pass on that consent and emergency level of access to you, the network lead. So I just want to talk a little bit about these data sharing agreements. So within any legal network in which multiple providers are participating, these are the agreements that are in place. And because of these agreements, we are allowed to pass through the consent level of access or the clinical emergency attestation level of access. So when these data sharing agreements are in place between the lead network and the network provider, we are able to share this client level data for the client based on what the providers are seeing. So just another way to think about this is that as a BHCC, as an IPA, as a hospital network user, when you have data sharing agreements in place with your network providers, you are going to see essentially exactly what the provider sees themselves in PSYCKES. So it's really allowing that same level of access. So one of the things that you might want to consider is when you've logged into PSYCKES, if you're seeing maybe, you know, I know this agency is under our network view, but I'm not seeing any of their clients here. I'm not seeing them included in our list of when I'm looking in their MyQI report, right? So that's something that if you need to update your list of network providers or provide us the update on status, maybe you didn't have a data sharing agreement in place with one of your providers, but now you do, you'll want to contact the PSYCKES help desk. And I have a slide towards the end that goes through exactly what that process is going to look like. So here are all the different levels of access to client data. So starting at the top, signed consent is the gold standard. So when you have a signed consent in place, this is going to allow access to all available data, including that data with special protection, for 3 years after the last billed service. So the difference between a PSYCKES signed consent form and a BHCC signed consent form is that the PSYCKES consent form is going to allow this data to be available between the provider who got the consent form signed and the lead network. Those are the two people that can get that access. When you have the client sign a BHCC consent form that grants users at that specific provider agency full access to the clinical summary, it also grants users at the lead network access to the full clinical summary, as long as that data sharing agreement's in place. And then third, this is not going to automatically grant users access, but if the BHCC has disseminated that this person has signed this BHCC consent form to their networks within their providers within their network, those network users just need to have that client sign that one BHCC consent form, and then they can go ahead and attest that the BHCC consent has been signed and be able to view that information. So that's the only two difference between a PSYCKES consent form and the BHCC. The PSYCKES consent form will be shared only among the provider who got this consent signed and the lead network, where the BHCC consent form covers not only the network, but also the providers within that network. There's also the verbal PSYCKES consent. So this is going to be if a client has verbally consented to PSYCKES, and this is something that we relied upon, especially during the COVID pandemic, but this would only allow access to limited data. So it doesn't include that data with special protections, and it's only available for 9 months. So that's just something else to keep in mind, is that if a client doesn't physically sign the consent form or a written consent form, there is the ability to verbally consent, but we would encourage providers, like after you get the verbal consent, do try to, circle back to this and get a written consent so you can expand your level of view to the client and that you are able to have that access for a longer period of time. And then we have the clinical emergencies. So this is a break the glass situation where this person is imminent risk of harming themselves or someone else, and we need to be able to act quickly. So we need to break the glass, and this will allow access to all available data, including that data with special protections, but only for that limited 72 hours. So here's just a helpful table that goes through all of those different scenarios. All right, so what information is going to be available about the clients in which my providers serve within my network? So you're going to be able to see aggregate data, so you're able to view current performance on all of the quality indicators, including the number of clients flagged at both the network and the specific provider level. You do very similar searches in statewide reports and then have the ability to review those proportions statewide, region, county, plan, other networks, other providers. And then you have the ability to run your recipient search report. So run a cohort search of interest within your network, and then obviously utilizing the utilization reports to help support your network data needs. So that's in the aggregate form. So for individual client level, you have the ability potentially to see a lot of information here, but it really does depend on those data sharing agreements being in place and having your providers really hammer home with your providers whenever possible, get those consents on file. So here you see the MyQI report. You have the ability to drill into the list of clients who meet the criteria for a selected indicator, but again, if you want to be able to drill in to see the clinical summary, not just the list of clients, you'd want to make sure that your providers are getting PSYCKES consents in place for you to be able to also drill in. Recipient search reports, you'll be able to view the names of clients who meet specific population search criteria. And then the clinical summary, again, access to this information up to 5 years, again, available with data sharing agreement in place and consent or ER enabled by one of your providers. All right, so now that we know how to access client information as a network user, let's talk about how we can use some of the reports in the application. So the recipient search tool is a tool for population health management and oversight. And the thing that we really want to make sure that we're pulling out is that the attribution when we're thinking about the recipient search is what clients have been served by one or more of your providers within the past 12 months. And you can always make some attribution time periods modified by making certain selections, but the default is the past year. And that's a little bit different than when we get to the MyQI report, because that's going to be in the past 9 months. So here you can build your own cohort searches, searching by particular demographics. So if you're doing anything related to health equity, you want to be able to run things about race, ethnicity, gender, et cetera. These are all only provided to us by Medicaid at this time, but that is a starting point to think about. We also have social determinants of health information that you're able to run searches on. You can think about some high need characteristics. So we have the high mental health need, Health Home Plus eligibility. And at the end of this month, we're going to also be adding something for complex needs. So a lot of different characteristics. So if you want to see what network clients that you have that have these certain characteristics, you can run these searches, as well as medication related, any diagnoses of particular interest, and also services that are being provided by your networks, or if you want to see services received by any provider. And you have the ability to run these searches, and you can start out, what we always recommend is starting out larger and then adding additional filters to kind of get smaller and smaller and smaller. So you can start with maybe like, you want to start with a denominator of like how many people receive this service, and then how many people have this diagnosis or this characteristic as a part of that population. You can export these results to an Excel or a PDF, and we have these advanced search results as well. So instead of having to drill into every single clinical summary, if you wanted to find out more information of like, all right, how many people in my Health Home Plus population also had suicidal ideations or had a history of homelessness, you have the ability to put on these advanced views to provide more information in bulk. All right, so what we have here is the recipient search landing page. So what we have at the top here in this purple box is how to run an individual search. So if I'm looking for one individual client, I can use their Medicaid ID or Social Security number, also known as like a unique identifier, to run a search to find a single individual. But if I don't happen to have that information on hand, I also have the opportunity to use a name, date of birth combination to the right over here. So everything in this box that's purple, that's considered your individual search criteria. And then everything in the blue box below, that's going to be your information to run cohort searches. So who at my Main Street network has, these particular characteristics, or has this high need population, or this specific social determinant of health, or is enrolled in this managed care plan, or has this HARP status. We also have the quality flag. So if I want to know who in my population have a particular quality flag concern, or on a specific medication or a specific drug class, or have a specific diagnosis. And then also receiving services, like how many people in my network are receiving crisis services, or how many people have been hospitalized more than 10 times in the past year, anywhere in the state. These are all the types of searches that you can run in recipient search. So we're starting here in the high need population. So here you can identify like, who are my people eligible for CORE, who are my people who are Health Home Plus eligible, who are my children who are high fidelity wraparound likely eligible, who have an active AOT court order, lots of different types of populations you can utilize this drop down for. We also have the quality flags here, and you can see the quality flags as of date. So the latest refresh was last month, which was July. We're currently in our QA process right now. So at the end of August, we'll have August as of 8/1. for quality flags. So here where you can select multiple different quality flags, and when you're selecting multiple different variables within a list, that's going to create an OR criteria, whereas when you're selecting it between lists, that's creating an AND logic. Oh, and just to mention, we have our definitions tab here. So if you want to have a better understanding of who's getting flagged for what, you have that ability to select that here. Medications and diagnoses, you have the ability to, again, search for a specific drug name, see if it's an active drug, so if it's been prescribed in the past 3 months. You also have any medications that require a prior authorization. You can search by a specific drug class, either non-psychotropic or psychotropic. And then you have the ability to expand these trees. So if I clicked on this, this would open up and give me the list of different specific types of anxiety disorders. So if you wanted to get a little bit more finite in your search, you have the ability to open up these particular medical diagnoses, or you have the ability to free type and use a fuzzy logic to make your selection here. And then we have services by a specific provider. So I'm Main Street Network. So this is going to only show me service settings that are provided within any of the providers that are currently within my network. So if I wanted to know who in my network have received services for care coordination, or if they received services for outpatient mental health clinic services, again, just like with the diagnoses section, I could expand this and see the different details here. And then here's services by any provider. So one of the examples I was saying before is if I wanted to know how many people have had any type of ER visit for behavioral health. So this example right here, and instead of just 2 or more in the past year, I really want to focus on my highest utilizers. So I could come over here and make this 5 or more in the past year, 10 or more, 20 or more. So I could run these searches to really have the best understanding of who are my high frequent flyers when it's coming to the ER, coming to inpatient, and how can I connect them to some community resources to assist them and help them stay out of the hospital. All right, so here we get to the page. So here's an example, my Main Street Network. In my network, we have over 600 recipients who've had 5 or more visits in the past year to ER for a behavioral health cause. So now I want to know of that, if I'm able to maybe apply a different view. But before I do that, I just want to make a couple updates here. So one of the things that we updated in the previous release is adding race and ethnicity. And this came directly from our network users asking for this to be added to the recipient search page to help with health disparity work. So this is going to be added in the recipient search results as well as all of our advanced views. And again, this information is coming directly from Medicaid billing. But now let's talk a little bit about our advanced searches. So here, when you click the eye, you can see exactly what's going to happen if I apply this results view. So what information am I going to see? Is it going to be information related to care coordination, high need, high risk, hospital utilization, or outpatient providers? So these are all of the columns that are available within these advanced views. I'm going to put on an example for high need, high risk. Now, another thing I want to make clear here is, let me just jump back here. You can see in this example that of the 3 people you can see on my screen, only one of them would be selectable because I have PSYCKES consent. So that means someone in my provider network got a PSYCKES consent for this individual and enabled it in their view, in their provider level view. What happened was that PSYCKES was able to check, okay, this is a network provider within this network, and we also confirm that they have a data sharing agreement in place, so we can okay them, the lead network, to be able to drill into this information. So when you're seeing no access, that means either you don't have a data sharing agreement in place with the provider, and or the provider did not get or wasn't able to get consent, and it, one of the, either their consent or it's not a clinical emergency. So it's really, if you want to make sure that as a lead network, you can get the fullest picture possible, it's great to talk to your provider agencies within your network and say, whenever possible, try to get the PSYCKES consent, bake that into your intake process, have that be part of your first meeting, getting that information when you can, because not only will it give that information to the provider, but it'll allow you as a network that fuller picture to help with your work as well. Because here's an example of when only 2 consents are available. So even though there's a whole list of all of these recipients, I'm only going to be able to see, when I scroll from left to right, information for people that had a consent in place, because I have no access to these clients. So besides their names, I'm getting nothing else. But for these ones that we are able to see, I can see that not only is this person having 5 or more ER visits for behavioral health cause in the past year, but they're eligible for OPWDD, NY START services. Both are Health Home Plus eligible, one of which had a homelessness service in the past year, as well as an overdose risk and suicide ideation. So lots that you're able to see in that advanced view, as long as you have your providers really, enabling access whenever they can. All right, so now we're going to talk about the MyQI report. So it's a tool for managing quality improvement efforts, and it's updated on a monthly basis. And this is part of the application. It's going to display quality indicator sets and individual indicators, which are known as flags or measures. And the way that this report works is that we have the eligible population, which is also known as the denominator. So this is going to be, in most cases, that's going to be the number of clients served by one of your network providers in the past 9 months, and any other parameters depending on the quality indicator specifications. And the specifications typically differ from measure to measure, so it's always important to, check out those technical specifications that we have listed on our public website under the quality indicators page. Then we have, after we've identified the eligible population count, then we have number with QI flag. So the number with QI flag is going to be what's also known as the numerator. So that's going to be the number of clients, and again, there's a little asterisk here as well, number of clients that meet that criteria for a specific quality flag. And the reason these 2 bullets have asterisks now is that certain flags have now been transitioned to events and episodes based versus client and individual based. And my next slide is going to go into a little bit more detail about what that means. So now that we know how the denominator and numerator are identified, the next is going to be what the prevalence rate is for your network providers. And you have the ability to basically take that numerator over denominator, get your network prevalence rate, and have the ability to compare that to the state. So how is my network doing when I compare how we've been handling this particular quality flag comparatively to the state? And you also have the ability to compare those to the region, county, network, program, managed care plan, other ways too. And that's something that can be done in the statewide reports. You also have the ability to filter the reports. So if you wanted to know, like, of the people that my providers are serving in the outpatient mental health clinic, or I want to know who out of this particular managed care plan, like, how are we doing with their attributed folks? Or if you wanted to be able to search by a particular age range, you have these abilities to filter the reports thus far. And like any other reports in PSYCKES, you're able to export to a PDF or an Excel. So here's where I'm talking a little bit about those events episode-based quality flags. So in our most recent sprint, we were able to update that because historically in PSYCKES, measures, numerators, and denominators were always based on the count of unique individuals. But starting in August, we were able to transition some of those existing quality flags from first phase, starting with our performance tracking measures, from an individual-based count to an events episodes-based count. So what does that mean? So like, for example, like having no follow-up after an MH inpatient for 7 days. So if I haven't had a follow-up after an MH inpatient for 7 days, what's going to be more helpful is not knowing like, okay, one client had no follow-up after MH inpatient 7 days, but how often was that client getting those inpatient stays and how many of those times were not getting a follow-up? So one person could have been hospitalized 5 times for mental health causes, and out of those 5 times, 3 of them did not result in a follow-up within 7 days. So previously, when it comes to a lot of those hospital-related measures, we were actually undercounting because we were only counting that person 1 time, when really, in fact, that was a 3-time missed measure. So that's just something to keep in mind, because certain DOH performance tracking measures basically are able to now capture the separate event or episode to calculate the measure's numerator and denominator. But what's great for networks and users is that when you drill down into the actual provider or recipient level tabs, those episode-based measures are going to continue to reflect the number of unique individuals. So I think my next couple slides will be able to display or help explain what that means. But basically, you'll start out getting like what the actual counts are of like how many of my discharges did not result in a follow-up for this population. And then when I'm able to drill down to see the providers of that work within my network, I can see like, okay, of those discharges that happened, 98 of those clients were at ABC Clinic. So I want to talk to ABC Clinic about getting something in place of making sure follow-ups are happening. All right, so now let's talk about how to understand the MyQI report. So as a network user in the MyQI report, you're able to review your overall network performance on your quality indicators. And that means you're able to see comparisons of providers within your network and identify high volume opportunities for improvement. And you can have the ability in the MyQI report to drill down to that list of clients and access client level data in the clinical summary to support treatment review, planning, care coordination for those high risk clients when you have consent from your providers. So now I want to note that a couple things that we want to make sure that we're mentioning is that, again, you got to have those legal data sharing agreements in place with that specific provider, and that specific provider has the consent or ER. And then clients are attributed to providers in PSYCKES in the MyQI report that have been served by one of your provider agencies in the past 9 months. So providers within the network are identified when you have requested PSYCKES network access development. So again, if you're in your MyQI report and you're drilling in and you don't see a network provider in your list that you would expect, you just need to email the PSYCKES help desk. So let's talk about how we're attributing clients. So we already talked about this, served in past 9 months. But now let's talk about the period of observation. So the period of observation for a quality indicator is going to vary between measures, and it's going to depend on what that quality indicator definition is. So the example that we have here is going to be the period of observation for high utilization. That's actually going to be a 13-month look back. So that's an important clarification. So even though the time frame for an individual to be linked to an agency in the MyQI report is the past 9 months, because that's the attribution based on Medicaid, the period of observation is a different time frame. So that means that this person that has been served at one of your provider agencies in the past 9 months had X amount of ER visits or inpatient visits in the past 13 months. So that's why they got flagged. All right. So now let's look at the MyQI report. So as my network view, I'm able to see from left to right, like this is the indicator set. Here's the population. Here's the eligible population, also known as that denominator. So I'm able to see up at the top here who are the eligible population for these indicator sets, as well as how many flags. So this could be depending on the type, how many people or how many episodes. And then over here, this is going to be my prevalence. So numerator over denominator. And again, in PSYCKES, we're giving you the quote unquote bad news. So what you want is to have a lower number here than when you see the state. So when you're seeing the higher number, that means that there's room for improvement on your end. But if you are lower than the state, that means that you're doing better than the state when you compare yourself to the state. All right, so then we have our quality improvement indicators. So these are our more quote unquote real-time run measures. And then down below here are performance tracking. So this is run with the intentional lag of 6 or more months to allow for complete data. And this is subject to DOH. So we're subject to DOH updates when it comes to the performance tracking indicators. We also have the ability to filter this report. So if I wanted to know, okay, like how are we doing on these measures when it comes to people that are enrolled in my care management program? So when I run that, I can see, oh, look, we're doing much better compared to the state when it comes to care management over here. That's amazing. So that's just like something that you're able to look at, or if like, oh, that's some room for improvement in my care management, when it comes to polypharmacy, that's another way that you can target these numbers. So here's an example of me wanting to drill into a particular measure set. So this is the mental health performance tracking measure set. So when I drill in here, this is one of those examples where there's measures that are both either based on the specific population or individuals or based on the episodes. So the example that I'm looking at right now is going to be those who have had a no follow-up after a mental health ED visit in 7 days. So here you can see, what does that mean? It's the percentage of mental health ED discharges. That's the important key word there, discharges. So that's the amount of discharge events, not the amount of people, but amount of discharges among individuals 6 and older who have not had a follow-up mental health outpatient visit within 7 days of discharge. So of this list, there's 265 potential discharge, or there are 265 events, also known as discharges here, that did not receive that follow-up visit within 7 days of that discharge occurring. So of the 808 discharges that had occurred during this time frame, there's about 265 that didn't get the necessary follow-up, and that's where you're getting this prevalence rate. So here is just a drill in here where you're seeing that information and just going over those points that I was just making a moment ago. Now here, this is the list. This is when we drill in and we can see this new provider tab. And this is going to display all the providers within your network that bill for Medicaid. So here's how these providers are doing in these particular quality concerns. So you have the ability to sort this by the number of, so if you're looking for volume, because what's happening here with the number of QI flags is that this is now identifying individuals. So 82 individuals at ABC agency did not get the necessary follow-up that they needed after they were discharged within 7 days. So I have the ability to filter this report, or not filter, sort this report by, I wanted to go by the highest number. So this is my volume. Or if I wanted to go by prevalence, so even though 44 is high up there, this one's 56, so a little bit higher up. So maybe if I wanted to go for prevalence high versus volume high, I could do, that search as well. So when I drill in, this is another example of, here's an example where I have 2 consents that have been implemented at my provider level access. So when my providers are able to enable consent, that passes through to me as the lead network, whereas no access, that means there's either no consent in place or you don't have your data sharing agreements in place. So either way, you just want to make sure those 2 things are handled. So you're able to see all of the recipients who match this criteria, as well as their other quality flags, including race and ethnicity, their current PHI, et cetera. So another thing that I want to show based on race and ethnicity has to do with our race and ethnicity view. So you have this advanced view where you can change this from the standard to race and ethnicity. And this is going to display the percentage and number of clients that are flagged for each of the quality indicators, and they're going to be broken out into the different race and ethnicity groups based on Medicaid, because Medicaid is our data source for the race and ethnicity information at this time. So the race and ethnicity view is applied to both the numerator and the denominator. And to calculate the percentage, what you do is have clients where they hit this particular race. So this is what this is showing in Medicaid for Asian, Black, Pacific Islander, white, multiracial, et cetera. So at this point right now, clients who identify with more than one race in their Medicaid registration are going to be listed in this multiracial group. Clients who identified as Hispanic or Latinx as their ethnicity are going to be represented in the Hispanic Latinx group. And then clients for which race is unknown is going to be included in the total, but won't be represented in one of these individual groups here. So here's an example of us looking at the no outpatient medical visit in over a year. So of this, I could take a look and see, okay, so of these measures that I'm seeing here, and I look and I'm trying to compare, so I'm seeing the comparisons here. So I see that of my Black population, about 18% did not have an outpatient visit in the past year. So I can hover over this because this is going to be the number. And then over here, the 7846, that's the denominator. So here's my numerator, over here's my denominator, so I can see where this prevalence rate came to be. And if I wanted to make any changes, this is something that I could like help focus on to see like what that health disparities may be. All right, moving right along. I know that we have about 15 minutes left and a few more slides to go. I think we'll have 15 slides to go for each of those 15 minutes, okay. So the clinical summary. So what's the clinical summary? So that's where the 5 years worth of information on managed care plan, product line, part status, medical behavioral health diagnoses, the medication services, hospitalizations, housing, anything for paid for by Medicaid, right? We're able to list that here in the clinical summary. And as a network user, you can view the client level information in the clinical summary for clients that have a data sharing agreement in place via the network, and the provider themselves has the client had consent or ER. So that's what this next slide is going through here, just reiterating when you're going to be able to view the clinical summary. So how do you look up a client? So we talked about this a little bit earlier. You navigate to recipient search, you enter in a unique identifier, or you can enter in the name and date of birth combination. So again, you're going to have probably better luck identifying one person when you're using a unique identifier versus if, you know, especially if somebody has a very common name like John Smith and a birth date, there might be a few people that come back. But again, like you're going to also be limited to the people that are available in your provider, who have been served by your providers and linked that way. All right, so here is just a fake Medicaid ID, searching for that, what that looks like. Here's an example of this person does show up here, but I see no access. So what's the reason for that? Either the provider that's serving John Smith doesn't have a data sharing agreement in place with Me, the lead network, or the provider did not, one of the providers within your network has yet to attest to a consent or ER access. So when they do have that consent in place, that's when you know you have your data sharing agreement in place and the provider was able to consent in their view of PSYCKES. So here's what the brief overview looks like of the consent form. So it's organized in different sections. So here at the top, it's the current care coordination section, so the who do I call list. So if I need to contact this person's care management or their health home, I have contact information here. Here's an example of the homeless, someone having homeless services outreach. So again, you have a contact here and you can see how recent this information is. Like you look here, this caseload started just a couple weeks ago, back in July. So that's again, like the beauty of some of our non-Medicaid data sources, having that really fresh available data. You also have notifications. So if this is called like the who do I call list, this is what's my client eligible for? So we can see if there's certain eligibilities that this client may have or things that should be made of note. So this person's considered Health Home Plus eligible. So one of the things I would want to make sure that they had is they're receiving Health Home Plus services. Medicaid eligibility alert. So if this person needs to have a specific type of recertification done, that's something that we'd want to get handled. If they're core eligible, maybe they're interested in finding employment, that might be something that would help them hook them up in that situation. We also have our alerts. So we can see that this person has had several homeless outreach services by DHS, as well as a shelter stay not too long ago. They've had treatment for suicide ideation multiple different times, as well as evidence of a opioid overdose. Down below there, we see our social determinants of health in the past year. So if any of these Z codes had been mentioned in the Medicaid claims, because right now social determinants of health information is coming from Medicaid specifically in PSYCKES, but we're hoping to expand that in the future. You'd be able to see that information in here. We also have the active quality flags that this person is currently active for, as well as any diagnoses in the past year organized by either most recent or most frequent. Then we have their medications in the past year that they've received. Here's an example. They all received these relatively recently in the past month, all on the same day. Then we also have their outpatient provider information. So when's the last time they were seen in the outpatient? And again, remember, versus the medications, which are, you know, pretty quick and timely, sometimes it does take a little bit longer for these outpatient and inpatient services to show. So it doesn't mean that this person maybe stopped going to their mental health specialty or their medical specialty clinic. It just means it's might be taking a little bit longer for that information to get into the application. We also have the all hospital and crisis utilization section. So here I can see that this person has had in the past 5 years several ER visits, as well as several inpatient admissions for both mental health and substance use, and at least one crisis telephonic service. So here's a lot of information that we can see here. And I'm just going to go back one slide here because this is just showing the brief overview and just meant for like a quick look for today's training. But when you have that PSYCKES consent pass-through, you also have access to the full summary. So if you want to drill in and see far more information, like the diagnoses in the past 5 years, the integrated view of services over time graph, care coordination history, that's all available in the full clinical summary. And if you're interested in learning more about the full clinical summary, we have training webinars that are based solely on that feature alone. All right, so let's talk quickly about the utilization reports. So what are these utilization reports? They were first created prior to a lot of our BHCC IPA initiatives in order to help providers identify other organizations that they might want to link up with. So it's also useful for networks to utilize. If you need to, you're realizing you're having some struggles when it comes to some of the substance use, let's say, indicators, maybe we want to make sure that one of our providers that we have in our network provides substance use services. So we have 3 different aggregate reports. The first is the Medicaid managed care plan and product line. The next is the provider network, and this is going to show all of the other providers who have served your agents, like all of the different agencies' clients, and they're not restricted to just your network. So then we have the service settings and volumes, and this report is going to give you a count of the total individuals and total service claims and encounters received by service type. So the functionality we have right now for the utilization report as a network user is that you first would select a provider in your network in order to view these reports that will show clients served by that particular provider. We're hoping as a future enhancement that we'd be able to aggregate reports for all clients served by any provider in your specific network. And we'd also, hopefully in the future, if we can get access to this information, have cost data. All right, so now we're looking at Main Street Agency. So that's one of my providers within my network. So I'm first looking at the Medicaid managed care product line. I can see the breakdown of my clients, where they are, and then the different product lines and the different managed care plans. Next, we have the provider network. So I can see here are the total clients that I have served at Main Street Agency, and here's their breakdown of all of the different services that they've had elsewhere as well. So if I wanted to maybe hook up with somebody who's providing some of the OP-SUG services, I could see how many of my clients are being served by other places and maybe link up with them, see if they're interested in joining the network. Then we have the service settings and volume. So here you're able to see the volume and type of Medicaid services provided by any agency, and compare that to your network's agency. So here's an example of, this is one of the providers within my network, and then comparing that to any of the other providers that are servicing clients and being able to compare their clients with services as well as the claims encounters by those specific clients. So here's an example, and then here's where your total ends up. All right, so now just talking briefly about training and technical support before I open it up to any questions that we might have. I mentioned this earlier today. So if you need to make any changes to your network view, you want to reach out to the PSYCKES help desk, and we'll provide you your network's latest spreadsheet on file. So for any network to be built, you had to have provided us the list of your network providers, and including their Medicaid ID, as well as their tax ID, as well as a lot of other information. So we have these Excels on file, and when there needs to be updates, what we do is we'll send you that Excel back to you, and you let us know what changes need to be had. So let's say, for example, Main Street Agency, they previously didn't have a data sharing agreement in place with my lead network, but now they do. So what I would do is I would look at my Excel, and I would highlight that agency that previously was a no in the data sharing agreement column, and I would highlight that row yellow to indicate, yes, this agency now has a data sharing agreement in place with our lead network. If we need to add new providers, we got a brand new provider agency in that wasn't previously part of our network. So Main Street agency is now a part of our network. We want to make sure to add them. Then you would add a new row in your Excel, and you would highlight that row green. So we would know green for go. This is a new agency. We want to make sure to include them in your view. Now, if you have any providers that are no longer part of your network, that's when you would highlight that row red. So that lets us know that this was a provider agency that was originally part of your network, but are no longer a part of your network, so they need to be removed from your network view. And again, you'll need to make sure that you're providing all relevant information, and this is something that we've talked about a few times with some networks, is that Excel has to have as much information as possible, especially when it comes to the provider's tax ID and Medicaid provider ID, because that's the information that we use to help link those views. And oftentimes, like when we're thinking about the MyQI report, that's done via Medicaid claims. So it's really important for any of your Medicaid billable providers to make sure that you have this information correct and in the correct format. Once that update has been made in your Excel, you just send that back to the PSYCKES help desk, and the updates should be reflected in the application within 1 monthly refresh, right? So if you emailed us today, we're already in the midst of QA, so we wouldn't be able to, have this readily available by the end of August, but we'll have it earmarked and make sure to have it ready for the September release. So that's just something to keep in mind, especially when you're thinking about timing. Having it before the beginning of the month is your best bet. All right, and then here's some of our technical support. So if you have any questions about the PSYCKES resources, just go to our PSYCKES website, full of different resources, trainings, user guides, etc. If you have any questions regarding the PSYCKES application, you just want to reach out to our PSYCKES help desk, and that's available 9 to 5, Monday through Friday via this email. And then if you're having any issues with logging in with your token, getting, certain error messages, you just want to make sure you're contacting the non-state PC help desk, which is emailing that help@its.ny.gov web email address. We always find that email is the quickest way that people get responses back from ITS. So making sure that you're contacting them and getting that settled. We're more than happy to act as the go-between if you reach out to us talking about issues with logging in. We'll try to work through that, but oftentimes it might need a PIN reset, or you might need something else, and that's unfortunately because tokens are used for all OMH applications, not merely PSYCKES. We just don't have the ability to reset PINs for folks, so we can always help communicate your needs to the ITS help desk. So with that, I'm going to turn it over to Michelle to see if there are any questions that came in during today's training.
Hey, Kristen. Yes, there are 2 questions, and the first question asked about medications in PSYCKES, and the user was wondering, is this capturing what's prescribed or what is dispensed or picked up from the pharmacy? So I had let them know it was medications that were picked up because we base it off claims data. So I just wanted to read that one out loud in case anyone else had that same question, or in case you wanted to add anything to that.
No, you covered it.
Okay. All right. And then the last question is, does a BAA suffice as a data sharing agreement?
Yeah, the BAA agreement absolutely does include the data sharing agreements in place. And you just want to make sure that you're getting that run through with those provider agencies as well.
Great. That is all the questions.
Awesome. Okay, so as I mentioned, these slides and recording will be available soon, if not today, by tomorrow, and then we're going to be posting this on our website. So if you have any new people joining who didn't get a chance to join today, that should be available up there shortly. And I really do appreciate people taking the time to learn more about PSYCKES today, and feel free to reach out to us if you have any questions. Have a great rest of your day.